Concept 29 from Concepts book, Pain. Goals for this concept presentation. Define and describe the concept. Notice risk factors for experiencing pain. Recognize when an individual has pain. Provide appropriate nursing and collaborative interventions to effectively manage pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. This definition describes pain as a complex phenomenon with multiple components that impact a person's psychosocial and physical functioning. The accepted clinical definition of pain, which was proposed by Margot McCaffrey in 1968, is accepted worldwide and reinforces that pain is a highly personal and subjective experience. Quote, pain is whatever the experiencing person says it is, existing whenever he says it does, unquote. This is why all accepted guidelines consider the patient's report to be the most reliable indicator of pain. Scope. Pain is a universal experience, although each person may experience pain in a different way. Conceptually, pain is a multidimensional symptom that can influence virtually every aspect of a person's life, the physical, psychological, emotional, social, and spiritual realms. The scope of pain as a concept may be viewed as a normal physiologic response to tissue injury or as a pathological symptom associated with a disease process or alteration of the somatosensory system. Normally, pain serves as a protective mechanism that is meant to alert the brain to potential or actual bodily harm or tissue damage, such as pain that results from an ankle sprain or fractured limb. However, pain that persists after the usual time for healing to take place serves no useful purpose and is viewed as pathologic. The concept of pain also ranges across several descriptive continuums, including location, intensity, frequency, and duration. In terms of location, pain may be well localized, such as in a joint, or widespread, occurring all over the body. The intensity continuum of pain ranges from none to minimal, moderate, and severe pain. The frequency of pain may be intermittent, occurring every few minutes, hourly, or daily, with episodes of no pain, or it may be constant without any breaks at all. Pain may be acute, such as pain that occurs directly after an injury and that dissipates with time as the injury heals. However, pain can also be chronic when it is associated with a disease process or when it persists after injury and may last for months, years, or a lifetime. Normal physiologic process. The sensations we experience in our body are orchestrated by an eloquent network of cells, fibers, and organs known as the somatosensory system, which receives, transmits, and interprets sensory information. Specialized sensory receptor cells carry specific types of sensory information: vision, hearing, touch, heat, cold, proprioception, and pain, along different anatomical pathways depending on the information carried. The cells of free nerve endings in the skin and peripheral organs that are somatosensory receptors for the sensation of pain are known as nociceptors. Nociceptors are found in all tissues except the central nervous system. Tissue injury activates nociceptors to transmit pain information through the somatosensory system, a process known as nociception. When the brain receives and interprets the information as unpleasant, painful sensation, it is known as nociceptive pain, which is a protective mechanism to alert the brain to potential or actual tissue damage. Although nociceptive pain requires the occurrence of nociception, nociception does not always result in nociceptive pain. The brain has a powerful influence on how we perceive sensory information and may filter or block pain information from awareness or change our perception of the sensory information. First proposed in 1965 by Melzack and Wall, the gate control theory is considered to be one of the most influential theories of pain because of its focus on a neural basis of pain. The gate control theory asserts that non-noxious input can close the gate to the CNS, thereby preventing painful input from reaching the brain. In this manner, non-painful stimulation is able to suppress pain. Since that time, it has become well recognized that pain is a complex condition involving numerous areas of the brain and is influenced by emotional, cognitive, and environmental elements. Neurological system. Pain is a conscious experience that requires an awareness of sensations via an intact CNS to receive sensory information and interpret the information as an unpleasant and painful sensation. The mechanisms that lead to the perception of nociceptive pain are described here and illustrated in Figure 29-2, page 285 in Concepts. Transduction. Tissue damage results in the release of chemical mediators from damaged cells that activate nociceptors. These chemical mediators include prostaglandins, bradykinin, serotonin, substance P, and histamine. When the chemical mediators attach to the membrane of the nociceptor, this can result in the opening of sodium channels that activate the nociceptor and cause the generation of an action potential. Transmission. The action potential subsequently moves from the site of nociceptor activation along specialized afferent AFFERENT nerve fibers that carry pain impulses, known as alpha 8 and C fibers, to the spinal cord. Alpha 8 fibers are thinly myelinated sensory fibers that send pain impulses faster than unmyelinated C fibers. Due to the myelin covering the alpha 8 fibers, they are capable of transmitting sharp stabbing pain sensations, whereas C fibers transmit aching, burning type pain sensations. Substance P and other neurotransmitters allow the action potential to proceed across the cleft to the dorsal horn of the spinal cord, where it ascends the spinothalamic tract to the thalamus and midbrain. Perception. Fibers from the thalamus send the nociceptive message to the somatosensory cortex, frontal and parietal lobe, as well as the limbic system, where pain is perceived and interpreted based on past experience, beliefs, attitudes, and meaning. Modulation. Activation of the midbrain results in the release of substances such as endorphins, enkephalins, serotonin, and dynorphin from neurons that descend to the lower areas of the brain and spinal cord, stimulating the release of endogenous opioids that inhibit transmission of pain impulses at the dorsal horn. Age-related differences. The mechanisms of nociceptive pain are normally present at birth and remain functional throughout the adult lifespan. The presence of acute pain remains approximately the same across the adult lifespan. However, there is an age-related increase in the prevalence of chronic pain, which affects more than 50% of older persons living in the community and greater than 80% of nursing home residents. Although chronic pain is prevalent among older adults, it is not a normal part of aging. Clinical studies have shown that elderly individuals are more vulnerable to chronic pain and that the ability to tolerate severe pain decreases with age. Variations in context. Acute and chronic pain. Pain is usually described as being acute or chronic, persistent. Acute pain is of sudden onset and is typically clearly linked to a specific event, injury, or illness. For example, tissue damage as a result of surgery, trauma, or burns produces acute pain, which is expected to be relatively short-lived and to diminish with normal healing. However, there may be variations in the intensity, frequency, and duration of pain between individuals after having the same surgical procedure or injury. This is why the subjective report of pain is so important. The experience of pain is highly individualized. However, when referring to acute pain, it is expected to dissipate with time along with the normal healing process. In contrast, chronic pain is defined as pain lasting more than 3 months and may last for years. Chronic pain may be resulting from underlying medical conditions or pathology, such as cancer pain from tumor growth or osteoarthritis pain from joint degeneration. Chronic pain may also develop from an injury, medical treatment, inflammation, or unknown causes that alter the somatosensory system in the periphery, spinal cord, or brain. As an advancement from the gate control theory, which describes the origins of pain, The neuromatrix theory posts that pain is the output of the neural network that is genetically determined and modified by sensory experience throughout life. This theory has promoted new thinking about chronic pain conditions such as fibromyalgia that do not have an obvious cause but are associated with changes in the CNS. Chronic pain can persist throughout a person's lifespan and varies in intensity, frequency, and duration. In addition, patients may experience both acute and chronic pain, such as when a patient with chronic cancer pain experiences acute pain after undergoing a painful procedure related to cancer treatment. Pain classification. Pain is most often classified by its inferred mechanism as being either nociceptive pain or neuropathic pain. Nociceptive pain refers to normal functioning of the somatosensory system in response to noxious stimuli or tissue injury that is perceived as being painful. Simply stated, nociception means normal pain transmission. Normal transduction of pain sensation by nociceptors is also known as eudynic pain, EUDYNIC. Examples of nociceptive pain include pain from a sunburn, surgery, or trauma. Patients often describe this type of pain as aching, cramping, or throbbing. Nociceptive pain may also be categorized as somatic or visceral. Somatic pain is characterized as sharp pain that is well localized to a specific area of injury. Visceral pain arises from within the body cavity, most commonly the thorax, abdomen, and pelvis. Pain receptors in the visceral cavities respond to stretching, swelling, and oxygen deprivation, and the pain may radiate to other locations in the back or chest. Although the normal mechanisms of nociceptive pain occur from stimulation of nociceptors, pain may also occur as neuropathic pain, which results from a pathology or disease of the somatosensory system. Simply stated, neuropathic pain is pathologic. Examples of neuropathic pain include post-herpetic neuralgia, diabetic neuropathy, phantom pain, complex regional pain syndrome, trigeminal neuralgia, and post-stroke pain syndrome. Patients with neuropathic pain use very distinctive words to describe their pain, such as burning, sharp, and shooting. Other forms of neuropathic pain are described by the mechanism involved. Sympathetically mediated pain is accompanied by evidence of edema, changes in skin blood flow, and abnormal sensations such as allodynia, hyperalgesia, and hyperpathia. Deafferation pain is chronic and results from the loss of afferent input to the CNS. The pain may arise in the periphery from a peripheral nerve avulsion or in the CNS from spinal cord lesions or multiple sclerosis. Neuralgia pain is lancinating and associated with nerve damage or irritation along the distribution of a single nerve. Central pain arises from a lesion in the CNS, usually involving the spinal thalamic cortical pathways such as the thalamic infarct. The pain is usually constant with a burning electrical quality. It is exacerbated by activity, and hyperesthesia and hyperpathia and or allodynia are usually present. Some patients have a combination of nociceptive and neuropathic pain. For example, a patient may have nociceptive pain as a result of a peripheral tumor that is growing and activates nociceptors around actual tissue damage. If the tumor is pressing against a nerve plexus, the patient may also report radiating sharp and shooting neuropathic pain. Some painful conditions and syndromes are not easily categorized and thought to be unique with multiple underlying and poorly understood mechanisms. These are referred to as mixed pain syndromes and include fibromyalgia and some low back and myofascial pain. Consequences. Pain triggers a number of physiological and psychosocial responses and can produce a cascade of harmful effects in all body systems. Physiologic consequences. The stress response causes the endocrine system to release excessive amounts of hormones, such as cortisol, catecholamines, and glucagon. Insulin and testosterone levels decrease. Increased endocrine activity in turn initiates a number of metabolic processes, particularly accelerated carbohydrate, protein, and fat destruction and catabolism, which can result in weight loss, tachycardia, increased respiratory rate, shock, and even death. The immune system is also affected by pain, as demonstrated by research showing a link between unrelieved pain and a higher incidence of nosocomial infections and increased tumor growth. Unrelieved pain impacts the respiratory system, causing small tidal volumes and decreases in functional lung capacity, which can lead to pneumonia, atelectasis, and an increased need for mechanical ventilation. Effects on the cardiovascular system include increased postoperative blood loss and hypercoagulation, which can lead to myocardial infarction and stroke. Increased heart rate and blood pressure are autonomic responses to acute pain. Pain can affect a patient's level of physical functioning. When pain is experienced with movement or mobility, the patient may associate the movement with pain. In this situation, it is very important for patients to understand that non-use of the affected area and immobility can lead to muscle atrophy and joint contraction, which further promotes pain and impairs physical functioning. Sympathetic nervous system activation caused by acute pain decreases the release of digestive enzymes in the GI tract and slows peristalsis. When mobility is not restored after surgery or trauma, this can further impair GI function. In turn, many opioid medications used to treat pain can cause constipation, making it necessary to have routine stool softeners along with the opioid medications. Psychosocial consequences. Along with the array of physical consequences that can develop due to pain, chronic pain in particular may be associated with significant psychological and social consequences, including fear, anger, depression, anxiety, and reduced ability to maintain relationships, engage in normal activities, and continue to work. Pain that does not dissipate with normal healing and pain that is undertreated or untreated can have a negative impact on nearly every aspect of a person's life and result in psychological and social consequences. Risk factors. With rare exception, everyone experiences pain at some point during the course of a lifetime. However, some population groups and individuals are at higher risk of experiencing severe or unrelieved pain than others. Populations at risk. Infants and children. Neonates are at risk for pain primarily from procedures such as heel sticks, venipuncture, and circumcision. Critically ill infants are at very high risk for pain due to the high number of procedures performed. In the neonatal intensive care unit, sick neonates are commonly exposed to numerous painful procedures, including endotracheal, intubation and suctioning, insertion of chest tubes, and arterial and venous punctures. Infants, toddlers, and developmentally preverbal children do not have the cognitive skills to report and describe pain. Thus, other indicators besides self-report must be used to recognize and treat the pain. Older adults. Although not all older adults experience pain, the incidence of pain increases with age, placing this population at higher risk for pain than younger individuals. Pain has been shown to be very common in the older adult in the inpatient acute care setting and in the outpatient setting such as nursing homes. This is in large part because older adults suffer many of the conditions associated with pain, including musculoskeletal disorders such as degenerative spine conditions and arthritis. They are frequent recipients of surgical procedures and at increased risk of injury from falls and trauma, all of which can result in pain. Some pain syndromes such as post-herpetic neuralgia, post-stroke pain, and diabetic neuropathy are more prevalent in the older population. Cancer is more common in older adults than in younger adults, and as many as 80% of cancer patients experience pain as a consequence of the disease process as well as its treatment. The older adult is at high risk for undertreatment of pain as well. Many are reluctant or unable to report their pain because of illness or cognitive impairment. Research shows that clinicians fail to provide adequate analgesia based on the misconception that analgesics are not needed or fears that analgesics may cause adverse effects such as confusion and respiratory depression. Other population groups. Other risk factors for pain or undertreatment of pain include sex, race, and ethnicity. Across settings, women report a higher prevalence of chronic pain than men, which may relate to the various chronic pain syndromes that occur exclusively or predominantly in women, such as endometriosis and fibromyalgia. In experimental studies, women report lower pain thresholds, the amount of stimulus at which pain begins to be felt, and less tolerance for pain, the maximum level of pain that a person can tolerate. Such gender differences are linked in part to hormone levels. Social factors that have an influence on access to pain treatments include income and education and geographic location. Cultural and/or religious convictions may pose a barrier to reporting pain. In addition, a population group, military veterans, have increased vulnerability to pain due to the high risk of combat-related injury or trauma. Individual risk factors. A number of individual risk factors exist that place individuals at greater risk to experience pain or risk for having insufficient pain relief, including communication barriers, genetic predisposition, cognitive impairment, substance use, individuals who have sustained significant injury, and those suffering from conditions that are known to cause pain. Communication barriers. Regardless of age, anyone who cannot report pain is at risk for undertreatment of pain. These individuals are referred to as nonverbal and include infants, toddlers, the cognitively impaired, and anesthetized, critically ill, comatose, and imminently dying patients. Patients who speak a different language may not understand the questions asked by healthcare providers and may lack the ability to adequately describe their pain experience. Furthermore, they may exhibit behavioral responses to pain differently, and these cues may be missed or misinterpreted by nurses from different cultural backgrounds. Cognitive impairment or developmentally disabled. The prevalence and burden of pain is higher in cognitively impaired or developmentally disabled children and adults compared to healthy individuals. Although a majority of individuals with cognitive impairment or developmental disability are verbal and can use a self-report pain assessment tool, behavioral pain tools should be used as well for initial and ongoing assessments. Mental health conditions. Patients with a history or current use of illicit substances may be perceived as trying to obtain pain medication as part of their addiction. However, individuals with addictive disease also experience pain, and their report of pain should be addressed through multimodal therapies. Mental illness is a common comorbidity with chronic pain. A pre-existing psychiatric illness may affect pain severity. In addition, patients with chronic pain may develop depression or anxiety disorders, particularly when they feel powerless or view their condition as hopeless. When patients present with mental illness and pain, both conditions should be addressed. Injury or conditions associated with pain. Some of the most obvious risk factors for pain are traumatic injury, critical illness, surgical procedures, or other conditions associated with pain. Acute and chronic medical conditions that are classically associated with severe pain include fractures, cluster headaches, passing kidney stones, trigeminal neuralgia, pancreatitis, shingles, herniated disc, and late stages of cancer. Critically ill patients of all ages experience a significant amount of pain from underlying painful pathologic conditions and the repetitive painful procedures to which they are exposed during the course of care. Research has shown that the most painful procedure in the intensive care unit is turning, which underscores the high prevalence of pain in the critical care setting. Conducting a pain assessment. The gold standard of pain assessment is the patient's subjective report of the pain experience. A thorough pain assessment is obtained by asking the patient a number of questions, and it serves as the foundation for effective pain management. It is used to establish the initial treatment plan and determine when changes are needed. The components of a comprehensive pain assessment are presented here. Location or locations of pain. Ask the patient to point to the area or areas of pain on the body. Intensity. Ask the patient to rate the intensity of pain using a reliable and valid pain assessment tool. A number of scales and several language translations have been evaluated and made available for use in clinical practice and for educational purposes. The following scales are most commonly used. Numeric rating scale. The numeric rating scale is often presented as a horizontal 0 to 10 point scale, with word anchors of no pain at one end of the scale, moderate pain in the middle of the scale, and worst possible pain at the end of the scale. Faces Pain Scale Revised. The Faces Pain Scale Revised has 6 faces to make it consistent with other scales using the 0 to 10 metric. The faces range from neutral facial expression to one of intense pain and are numbered 0 2, 4, 6, 8, and 10. Patients are asked to choose the face that best describes their pain. The FPSR is valid and reliable for use in children and adults, including cognitively intact and impaired elders. Although young children may be able to select a face on a FACES scale, they are unable to optimally quantify pain, identify a number until approximately 8 years of age. Wong-Baker FACES Pain Rating Scale. The FACES scale consists of 6 cartoon faces with word descriptors, ranging from a smiling face on the left for no pain or hurt to a frowning, tearful face on the right for worst pain or hurt. The faces are most commonly numbered using 0, 2, 4, 6, 8, 10 metric. However, 0 to 5 can also be used. Patients are asked to choose the face that best describes their pain. The FACES scale is used in adults and children as young as age 3. Verbal descriptive scale. A verbal descriptive scale uses a series of different words or phrases to describe the intensity of pain, such as no pain, mild pain, moderate pain, severe pain, very severe pain, and worst possible pain. The patient is asked to select the phrase that best describes his or her pain intensity. The scale can be presented horizontally or vertically and can be helpful for patients with difficulty using a numeric scale. Quality. Ask the patient to describe how the pain feels. Descriptors such as burning or shooting may identify the presence of neuropathic pain. Onset and duration. Ask the patient when the pain started, what activities he or she was performing when it began, as well as whether it is constant or intermittent. Alleviating and relieving factors. Ask the patient what makes the pain better and what makes it worse. The answers help to determine which pain medications and non-pharmacologic interventions are effective and which are not. Effect of pain on function and quality of life. Ask the patient to describe medication side effects, constipation, nausea, sedation, and difficulty sleeping or eating. Assess for comorbidities such as anxiety and depression. It is particularly important to ask patients with chronic pain about how pain has affected their lives, what could they do before the pain started that they can no longer do, or what do they want to do but cannot because of the pain. Comfort, function, pain, goal. Discuss the expectations of functional goal achievement. For example, tell surgical patients they will need to deep breathe, cough, turn, and ambulate or participate in physical therapy after surgery. Patients with chronic pain can be asked to identify their unique, functional, or quality of life goals, such as being able to work, walk the dog, or garden. Ask the patient to identify, using a 0 to 10 scale, a level of pain that will allow accomplishment of the identified functional or quality of life goals with reasonable ease. A realistic goal for most patients is 2 or 3, and pain intensity ratings that are consistently above the goal warrant further evaluation and consideration of an intervention and possible adjustment to the treatment plan. Breakthrough pain. An important part of the pain assessment is to determine whether the patient is experiencing breakthrough pain and if its treatment is effective. Breakthrough pain can also be called pain flare, and it's a transitory exacerbation of pain in a patient who has relatively stable and adequately controlled baseline pain. When breakthrough pain is brief and precipitated by voluntary action such as movement, it is referred to as incident pain. Another type of breakthrough pain, called idiopathic pain, is not associated with any known cause and often lasts longer than incident pain. Episodes of pain that occur before the next analgesic dose is due is called end-of-dose failure pain. A fast onset, short-acting formulation of a first-line analgesic such as morphine, oxycodone, hydromorphone, or fentanyl is used to manage breakthrough pain. Analgesic doses or the frequency of their administration is adjusted as needed to minimize the occurrence of breakthrough pain. Reassessment. Following initiation of the pain management plan, pain is reassessed and documented on a regular basis as a way to evaluate the effectiveness of the treatments. At a minimum, pain should be reassessed with each new reported pain and before and after the administration of analgesics. The frequency of reassessment depends on the stability of the patient's pain and is guided by institutional policy. For example, in the acute care hospital setting, reassessment may be necessary as often as every 10 minutes when pain is unstable During the titration phase, gradual increases in dose to establish analgesia, and every 8 hours in patients with stable pain. Findings that warrant further evaluation or notification of the prescriber include pain ratings that continue to be higher than the patient's comfort function goal, a change in the location or quality of pain, and the development of medication-induced side effects that do not respond to treatment. Nurse monitoring of side effects is essential to ensure patient safety during analgesic administration. Life-threatening opioid-induced respiratory depression is the most serious of the opioid side effects. However, nurses can be key to preventing this complication by performing systemic assessments of their patient's sedation levels. Less opioid is required to produce sedation than to produce respiratory depression, a characteristic that makes sedation a particularly sensitive indicator of impending respiratory depression. Gradual increases in sedation level warrant prompt reduction of opioid dose and increased frequency of nurse monitoring until the patient demonstrates an acceptable level of sedation. Behavioral signs of pain: facial expressions, restlessness, change in activity, crying, and the assessment tools. Pain assessment. How does the nurse assess for breakthrough pain? How does the nurse conduct a pain reassessment? What are common challenges with pain assessment? When does the nurse use a surrogate to facilitate pain assessment? Hierarchy of pain measures. Obtain a patient self-report, consider patient condition or exposure to painful procedures, observe for behavioral signs of pain, evaluate psychological indicators, conduct an analgesic trial. Diagnostic tests such as X-rays, CTs, MRIs, or ultrasound may be used to examine the areas of pain to identify a potential reason. However, these should not delay appropriate treatment of pain. Clinical management. For most of the health and illness concepts presented in this text, clinical management includes all phases of health promotion, including primary and secondary prevention. However, the concept of pain, the relevant focus of clinical management, involves interventions to treat pain. Collaborative interventions, pharmacologic interventions. Because pain is a complex phenomenon involving multiple underlying mechanisms, a multimodal regimen which combines drugs with different underlying mechanisms is often indicated. This allows lower doses of each of the drug in the treatment plan, thereby reducing the potential for adverse effects, and can result in comparable or greater pain relief than can be achieved with any single analgesic. Guidelines recommended the use of multimodal analgesia for all types of pain. Analgesics. There are 3 major analgesic groups: non-opioid analgesics, opioid analgesics, and adjuvant analgesics. Figure 29.3 shows the first-line analgesics in each group. Non-opioid analgesics are appropriate alone for mild to some moderate nociceptive type pain and are added to opioid analgesics as part of a multimodal analgesic regimen for more severe nociceptive pain. For example, unless contraindicated, all surgical patients should routinely be given acetaminophen and a non-steroidal anti-inflammatory drug in scheduled doses throughout the postoperative course. Opioid analgesics are added to the treatment plan to manage moderate to severe postoperative pain. A local anesthetic is sometimes administered epidurally or by continuous peripheral nerve block. An anticonvulsant may be added to the treatment plan as well as to control severe pain or prevent a chronic post-surgical pain syndrome, such as post-thoracotomy or post-mastectomy pain. Anticonvulsants and antidepressants are first-line analgesics for neuropathic pain. These analgesics require a period of several days to weeks of dose titration to determine efficacy and safety and to achieve adequate pain control. Lidocaine patch 5% is used for well-localized peripheral neuropathic types of pain, such as post-herpetic neuralgia, shingles-related pain, And long-term opioid therapy can be effective for some individuals with neuropathic pain as well. It is not unusual to find a multimodal pain treatment regimen for a person with neuropathic pain that includes an antidepressant, anticonvulsant, local anesthetic, and an opioid. Routes of administration. A variety of routes of administration is used to deliver analgesics. A principle of pain management is to use the oral route of administration whenever possible. All the first-line analgesics used to manage pain are available in short-acting and long-acting formulas. For patients who have continuous pain, a long-acting analgesic such as modified-release oral morphine, oxycodone, hydromorphone, or transdermal fentanyl is used to treat the persistent baseline pain. A fast-onset, short-acting analgesic, usually the same drug as the long-acting, is used to treat breakthrough pain if it occurs. When the oral route is not possible, other routes of administration are used, including IV, subcutaneous, transdermal, and rectal. Opioids are often given by IV, patient-controlled analgesia, called PCAs. Patients who use PCA must be able to understand the relationships between pain, pushing the PCA button, and pain relief. They must also be able to cognitively and physically use the PCA equipment. Other routes for pain administration include intraspinal analgesia and continuous peripheral nerve block infusions with or without PCA capability. Nurses play a key and extensive role in the successful management of these therapies, and the American Society for Pain Management Nursing provides guidelines for care. As more information is gathered regarding how genetic factors influence the metabolism of medications used to treat pain and the side effects produced, a more patient-centered pain management approach may be used. Invasive or surgical strategies. Regional anesthetic strategies for pain management include epidural steroid injections to treat radicular pain, joint injections, nerve blocks, and implantation of intrathecal analgesic delivery systems. More invasive measures may include spinal cord stimulators, rhizotomy or neurectomy, nerve decompression, and joint replacement therapies. These intensive invasive procedures are typically performed after other treatment modalities have failed to provide pain relief. Non-pharmacological interventions. Non-pharmacologic interventions strategies encompass a wide variety of non-drug treatments that may contribute to comfort and pain relief. These include the body-based physical modalities such as massage, acupuncture, and application of heat and cold, and the mind-body methods such as guided imagery, relaxation, breathing, and meditation. In addition, psychological therapies such as cognitive behavioral treatment, biofeedback, and hypnosis may be used along with other therapies to help manage pain. There are also biologically based therapies which involve the use of herbs and vitamins, and energy therapies such as Reiki and Tai Chi. Non-pharmacologic methods may be effective alone for mild to some moderate intensity pain and are used to complement, but not replace, pharmacologic therapies for more severe pain. The effectiveness of non-pharmacologic methods can be unpredictable, and although not all have been shown to relieve pain, they offer many benefits, such as facilitating relaxation and reducing stress to patients with pain. Many patients find that the use of non-pharmacologic methods help them cope better with their pain and feel greater control over the pain experience. The following list provides examples of non-pharmacologic measures that are non-invasive and relatively easy to incorporate into daily clinical practice. They can be used individually or in combination with other non-drug therapies. Proper body alignment achieved through proper positioning and regular repositioning can help prevent or relieve pain. Pillows may be used to maintain the position and support for the patient's back and extremities. Thermal measures such as the application of localized superficial heat and cooling may relieve pain and provide comfort by decreasing sensitivity to pain and muscle spasms and alleviating joint and muscle aches. The two measures are often used interchangeably. Mind-body therapies are designed to enhance the mind's capacity to affect bodily function and symptoms and include music therapy, distraction techniques, meditation, prayer, hypnosis, guided imagery, relaxation techniques, and pet therapy. Clinical nursing skills for pain. You must do a pain assessment, a non-pharmacologic pain management, massage, splinting, relaxation and guided imagery, distraction, pharmacological pain management, oral medications, intravenous medications, epidural analgesia, patient-controlled analgesia, and local anesthesia. Interrelated concepts. Pain is connected to numerous concepts, with those considered more relevant listed here. They are presented in Figure 29.4. The expression and interpretation of pain varies widely across cultural groups, thus culture is an important interrelated concept. Having awareness of such differences is critical for nurses so that an accurate pain assessment can be conducted and appropriate pain interventions can be implemented. The expression of pain may also be influenced by one's spirituality. A person may be more accepting and tolerant of pain gained through spiritual strength. An individual's level of development impacts how pain is interpreted by the individual and the ability of that individual to communicate his or her pain. Nociceptive pain is typically associated with altered tissue integrity. Acute pain associated with compromised tissue integrity is expected to dissipate with the normal healing process. Mobility is an important interrelated concept because severe pain can be immobilizing to individuals, and in some of the most disturbing effects of unrelieved pain are seen in the musculoskeletal system with impaired muscle, skeletal, or joint function. Inadequately managed pain can affect functional ability. This is often seen in the post-op setting where the patient's ability to ambulate and participate in important physical therapy activities prolongs recovery and is associated with a higher incidence of complications, including long-term disability. In the outpatient setting, individuals with poorly managed chronic pain report inability to complete even the most simplest of activities of daily living, which can result in loss of independence and greater reliance on family, friends, and the healthcare system. Patients with poorly managed chronic pain frequently report sleep disturbances, and sleep disturbances can contribute to increased pain perception as well as a reduced ability to cope. Pain also leads to fatigue, particularly when sleep is impaired. Increased levels of fatigue along with pain can further impair mobility and functional ability. Pain also affects mood and affect. Patients with severe pain are more likely to rate their general health as poor and describe having suicidal thoughts. Research has even shown that severe chronic pain is associated with increased mortality, independent of socio-demographic factors such as income, age, and gender. Clinical exemplars. As mentioned previously, most individuals experience pain across the lifespan and in very many different ways. Thus, the nurse will encounter multiple situations that will require pain assessment and interventions. The discussion of each situation is beyond the scope of this concept analysis. However, box 29.1 on page 290 in Concepts presents the most common pain conditions in the context of the major categories of pain. Featured exemplars. Osteoarthritis pain. Osteoarthritis is a condition that causes the cartilage in a joint to become stiff and lose elasticity. As this occurs, the cartilage can wear away, causing tendons and ligaments to stretch and bones to rub against one another, resulting in pain. Osteoarthritis commonly affects the hands as well as weight-bearing joints and is more frequent in women than in men. Osteoarthritis pain is an example of nociceptive somatic pain. Trigeminal neuralgia, also known as tic douloureux. Trigeminal neuralgia is a form of neuropathic pain arising from the trigeminal fifth cranial nerve. It causes extreme sporadic burning or shock-like facial pain that can last seconds to minutes per episode. The intensity of pain can be physically and mentally incapacitating. Postherpetic neuralgia. Another type of neuropathic pain is postherpetic neuralgia, which develops after a case of shingles caused by the herpes zoster virus. Typically, thin blisters associated with shingles disappear within a few weeks, but when the pain continues after the blisters have disappeared, the burning pain is known as postherpetic neuralgia. The incidence of postherpetic neuralgia increases with age. Post-stroke pain. More than half of all stroke survivors report some form of post-stroke pain. It can occur immediately following a stroke or weeks to months afterwards and may affect any area of the body. Patients typically describe burning pain or unpleasant and painful pins and needles sensation. Complex regional pain syndrome is a form of neuropathic pain that affects one of the limbs, arm, leg, hand, or foot, after an injury or trauma of the limb. It is characterized by prolonged or excessive pain and mild to dramatic changes in skin color, temperature, and swelling of the affected area. It is more frequent in women. Fibromyalgia. Fibromyalgia is a mixed pain disorder that is associated with widespread musculoskeletal pain, fatigue, sleep disturbances, and cognitive and mood disorders. Symptoms often begin after physical trauma, surgery, infection, or significant psychological stress and accumulate over time. Fibromyalgia is more common in women. Phantom pain. Phantom pain feels like it is coming from a body part that is no longer there. Although phantom pain most often develops after removal of an arm or a leg, with up to 75% of patients developing pain within the first few days after limb amputation, it can also occur after removal of other body parts. Many factors are thought to influence the risk of phantom pain, particularly pre-amputation pain and genetic factors. However, phantom pain is thought to originate in the brain. Multimodal therapies are often required to reduce pain, although most patients experience a decrease in pain over time. Question. Pain that results from the abnormal processing of sensory input by the nervous system as a result of damage to the brain, spinal cord, or peripheral nerves is called persistent pain, acute pain, neuropathic pain, or nociceptive pain. The answer is neuropathic pain is pathological. Examples of neuropathic pain include post-herpetic neuralgia, diabetic neuropathy, phantom pain, and post-stroke pain syndrome. What is the most reliable indicator of pain? Healthcare provider assessment of pain symptoms, fluctuation of vital signs, amount of pain medication required to ease the pain, patient's report of pain level. Which pain assessment tool asks the patient to rate the intensity of pain using a 0 to 10 point scale? Is it FACES pain scale, numeric rating scale, Wong-Baker FACES rating scale, or verbal descriptor scale? It should be numeric rating scale is the most often presented as a horizontal 0 to 10 point scale with word anchors of no pain at one end of the scale, moderate pain in the middle, and severe pain at the end. This is the end of the slideshow.